Anterior cruciate ligament injury is the most common serious knee ligament injury seen in any busy sports medicine practice. Anterior cruciate ligament injury disrupted the careers of Gale Sayers, Bobby Orr, as well as Joe Namath. When one hears of an athlete who has a knee injury and is expected to be out of action for 6 to 9 months, anterior cruciate disruption is most often the reason. Anterior cruciate ligament injury must be treated. It cannot be ignored. The treatment may take one of two approaches: a conservative approach involving rehabilitation, bracing, and most importantly, limiting the sports each athlete involves him or herself in, or through a surgical approach which rebuilds the ligament. In either case, the treatment must be proactive and the patient must dedicate him or herself to achieving a functionally stable knee. Anterior cruciate ligament injury may be treated differently according to the athletic expectations and interests of each patient. However, before making a decision on whether to go ahead and surgically rebuild or reconstruct this ligament, or to instead try to compensate for the missing stabilizer through exercise and bracing, it is important for the patient to understand the natural history of ACL insufficiency, or what happens to the knee following this injury. The anterior cruciate ligament, or the ACL, is located in the center of the knee joint and connects the leg bone or tibia to the thigh bone or femur. The ligament is shaped like a short length of nylon rope and carries on its surface its own blood supply. When the anterior cruciate ligament tears, its blood supply is also disrupted. And without a blood supply, the anterior cruciate ligament has no ability to heal. The ligament will never tighten, nor the knee become more stable. With the ligament torn, the knee becomes functionally unstable. That is, the knee will buckle unexpectedly in activities that require quick changes in direction, cutting, deceleration, or jumping. Importantly, when we talk about the natural history of anterior cruciate ligament injury, or the way in which various people are affected by the absence of the ligament, we're speaking about a statistical norm. The degree to which individuals are troubled by the lack of the ACL can best be represented as a bell-shaped curve. On one tail of the curve are a few unfortunate individuals who are so troubled by anterior cruciate ligament instability that they have difficulty in daily activities, such as simply getting out of a car, walking off a curb. On the other extreme of the curve are found a small group of people who are able to play high-level or even professional sports without instability, despite their absent ligament. As a rule, however, the great majority of people find themselves in the large area underneath the central body of the curve. They generally do well in activities which involve straight-ahead motion, such as running, biking, swimming, fitness-type activities, and do poorly in activities that require jumping, cutting, or changes in direction. One of the most important factors entering into the decision on whether you have your ligament surgically reconstructed or alternatively treating your ACL conservatively with bracing and exercise is which of these previously mentioned sports categories best describes your activity level.
Do you participate in high-risk sports such as basketball, football, soccer, or aggressive skiing? Or moderate-risk athletics, including recreational tennis, softball, or intermediate skiing, which all require some control of lateral motion? Or do you keep fit by participation in aerobics, running, speed walking, or weightlifting, or sports which require no rapid change in direction or acceleration, such as bowling or golf? We do know, however, if you continue to play high-level jumping and cutting sports, there is a great likelihood that the knee will repeatedly buckle beneath you, leading to recurrent injury, pain, and swelling. We call these recurrent episodes of instability giving way. During a giving way episode, the bones of the knee slide apart, trapping and tearing the cartilages and further injuring the already compromised joint. These instability events produce painful meniscal tears, which often require repeated arthroscopic surgeries or meniscectomies. Unfortunately, when both the anterior cruciate ligament and one or both cartilages are injured, significant arthritic changes will likely develop by middle age. Bone-on-bone arthritis in individuals in their late 20s or 30s are all too commonly seen following missed or untreated anterior cruciate ligament disruption.
No matter how you choose to treat this ligament injury, the end result must be the same: to keep the knee from buckling. A decision to treat the ligament conservatively is not a final decision. It merely affirms that you're going to rehabilitate the knee, Brace it during moderate risk sports, and then continue to evaluate your function as you return to activity. If the knee does not remain stable as had been hoped, but rather repeatedly gives way, the decision not to operate must be revisited, and the ACL reconstruction must be performed before significant meniscal or joint injury occurs. We generally recommend early anterior cruciate ligament reconstruction without an initial trial of conservative care for three groups of patients: individuals who are actively involved in jumping and cutting sports, such as competitive tennis, football, soccer, basketball, or volleyball. These folks generally do poorly with a conservative approach, and we feel early reconstruction gives these athletes the best chance of safely returning to their previous level of competitive activity. Teenagers, because of their high level of activity, fall into the surgical group as well. This is true even if they're not involved in organized sports. Children and young adults in this age group are so athletic and active that the conservative treatment of this ligament injury generally fails to protect the knee, and accordingly, conservative approach is almost never considered. Lastly, individuals who, in addition to the anterior cruciate ligament, have a second completely torn ligament will require a surgical repair. The combination of both an anterior cruciate ligament and a second collateral ligament produces such great instability that reconstruction is almost always undertaken.
Before discussing ACL reconstruction, it is best to briefly review the anatomy of the knee. The ligaments of the knee, two external collateral ligaments, in concert with the central cruciate ligaments, securely connect the femur or thigh bone and tibia or leg bone. Lying between these bones and acting as shock absorbers are the meniscus, commonly called the knee cartilages. There is a meniscus on either side of the knee. The ends of the tibia and femur, as well as the undersurface of the patella or kneecap, are covered by an entirely different type of cartilage substance called the articular cartilage. This linoleum layer protects the underlying bones as the joint moves. The ACL sits in the center of the knee, just below the patella and between the medial and lateral meniscus. Seen in cross-section, the ligament attaches to the femur and tibia and limits joint distraction during jumping, lateral motion, or sudden deceleration. Unlike other ligaments around the knee, the ACL cannot heal after injury. The torn anterior cruciate resembles a mop with multiple strands and fibers that is impossible to surgically repair. Unable to heal and impossible to suture, the ligament must instead be replaced by portions of available tissue from around the knee. Commonly used grafts are fashioned from the quadriceps, patella tendon, or hamstring tendons. The replacement of the shredded ligament with viable tissue grafts is called an ACL reconstruction. ACL reconstructions have been performed for the past 30 years. It is currently done arthroscopically with decreased postoperative pain, decreased scarring, and quicker return to function. The surgical procedure is very mechanical, and once the graft has been fashioned, involves essentially 5 separate steps. In step 1, a tunnel is prepared in the lower bone or tibia. In the first step, a drill guide is introduced into the knee and placed at the center of the lower surface of the joint. A 3 mm pin is then introduced through the guide system and enters the knee at the ACL's previous attachment site. A drill bit with a hollowed core is then slid over the pin and advanced with surgical power into the knee. The drill bit measures only 8 to 11 millimeters in diameter, requiring only small skin incisions. When finished and the drill bit withdrawn, a tunnel remains which will house the lower segment of the soon-to-be reconstructed ligament. The second step is technically similar to step 1. In this part of the procedure, however, a tunnel is fashioned in the femur or upper surface of the knee. Using special instruments, the precise site of the upper tunnel is marked and the guide pin once again inserted. The cannulated drill bit is again advanced over the femoral guide pin, creating a second tunnel which will hold the superior portion of the newly reconstructed anterior cruciate ligament. In the next 2 steps, the graft will be passed and then fixed into their respective tunnels. In the third step, a beef pin, which resembles a long knitting needle, is advanced into the knee through the lower tibial tunnel. The knee is flexed and extended to line up the 2 tunnels in parallel fashion and the beef pin then directed into the upper femoral tunnel. As the pin is withdrawn superiorly, the graft attached to the lower end of the pin is pulled into the joint until it is well positioned in both tunnels. In the fourth step, using either metal or absorbable screws or other fixation devices such as endo buttons or suture posts, the graft is firmly secured within their respective tunnels. In addition to attending to the torn ACL, any meniscal or cartilage injuries must also be treated. Meniscal or cartilage injury occurs in fully 1/3 of acute ACL tears and in 70% of chronic injuries. Depending upon the pattern of the meniscal injury and the presence of adequate blood supply, we will either repair or resect the damaged portion of the meniscus as demonstrated in these two slides. Surgery is performed as an outpatient procedure at Hackensack University Medical Center's ambulatory unit. Initially, crutches are needed for walking, but can generally be disregarded within 2 to 3 weeks.
In general, students return to school at 10 days. Individuals who work in an office setting generally can expect to return to work between 1 and 2 weeks. Those, however, involved in more physically demanding jobs have variable returns of work depending upon the nature of their job and the necessity to spend long periods of time standing, walking, or kneeling.
Physical therapy is added to a home exercise program and continued until strength and function are both recovered. 4 months from surgery, sport-specific footwork and quickness drills are instituted. Return to sports is allowed when strength and agility have both recovered. For most individuals, this occurs somewhere at 4 to 6 months following reconstruction.
The results of surgery vary in the literature from 75 to 90%, which leaves you with an excellent chance of a strong, stable knee. The risks and complications at surgery are important to understand before deciding to proceed with reconstruction. Graft failure occurs as noted in 15% of cases. Graft failure may occur from either re-rupture or stretching out over a period of time. The reason underlying graft attenuation or stretching is presently unclear. Certain grafts appear not to revascularize. Normally, blood vessels from surrounding tissue penetrate the tendon graft and repopulate it with fibrous cells. If this revascularization or repopulation process doesn't occur, the ligament will eventually stretch out and fail. In other individuals, the newly remodeled ligament may re-tear with recurrent injury. If the ligament fails, you would be left essentially as you are now with an unstable knee and consideration for a second reconstruction. Another general complication is that of infection, which occurs roughly 1 or 2 times in each 100 open surgeries. Other general risks include loss of motion, or what we call arthrofibrosis. In order to prevent stiffness or loss of motion, we begin moving the knee soon after your surgery and continue with a very rigorous program to get full extension and flexion as soon as possible. Another problem after ACL surgery is kneecap or patellofemoral pain. Kneecap pain is characterized as a deep and achy discomfort under the kneecap, which is generally aggravated by stair climbing, sitting for long periods of time, or extended activity. Kneecap pain generally occurs in roughly 30% of individuals undergoing anterior cruciate ligament surgery. This disappears, however, in most people by the end of a year.
Other complications not specific to ACL surgery include deep vein thrombosis, pulmonary embolus, nerve or vessel injury.
Again, the great majority of patients do well following ACL surgery, though a full appreciation of these known complications are important to the patient and his or her family before proceeding with the decision to surgically reconstruct this ligament. Whether surgically or conservatively treated, anterior cruciate ligament injury requires ongoing treatment and commitment. In either case, much rehabilitation and work lies ahead before he or she may safely and comfortably return to the lifestyle or occupation they have chosen. I hope this has been of assistance to you. If there are any questions, please don't hesitate to ask in the ensuing question and answer period.